I went to medical school at University of Washington in Seattle, trained in internal medicine. I was a software developer before I went to medical school, planned on doing medicine. Did my residency at Portland, Oregon. During my residency, I also taught at clinical informatics at Oregon Health and Sciences University, started a software company. Software company was acquired by WebMD, went to WebMD, met my former CEO there, who I followed to Healthgrades. And I guess that's sort of a whirlwind of kind of like where I've been. So I love clinical medicine, and I'm the kind of result of a hobby that got out of control. And I'm just seeing where this is going. Yeah, and I guess that was the one thing I hoped we were going to talk a little bit about here today, because this kind of early COVID piece is very different than what we traditionally do sort of at Healthgrades and stuff. And I can give you the backstory kind of on the origin story, if you will, on that if you'd like. But, traditionally what we do is we rank hospitals based on only two criteria: death and complications. Those are the only two clinical indicators we use. We don't have a popularity or reputation component or a subjective component to what we do. So we look at hospitals on those two things specifically. We then risk adjust the case mix of a hospital based on demographics and comorbidities to determine a predicted number of deaths and complications for 31 clinical cohorts that we rank. We then compare those to the national averages, and then we measure the actual versus the predicted in our hospital outcomes. And essentially we use kind of a 1.650 standard deviations from the mean to determine kind of our 5-star hospitals versus our 1-star hospitals and stuff like that. So. I think so. Obviously, I wasn't there on the front lines, kind of whatever, but what we did see, and I guess kind of where this story that we sort of wrote started, was really kind of one aspect of this was it was almost kind of like a virtual water cooler meeting, where somebody commented on how COVID patients were being unevenly distributed to healthcare facilities, meaning that many of us had kind of seen in our local markets that there was either like a magnet hospital or some other hospitals that were becoming kind of the designated COVID hospitals, whereas other hospitals were seeing very few COVID patients. And you could speculate kind of why this may be. I mean, these tended to be larger institutions with very large ICUs, probably had lots of ventilators around and that kind of stuff as well. And we also saw even the hospitals that weren't seeing a lot of COVID patients were oftentimes now seeing overflow of kind of routine chronic care and other stuff that would have been normally being seen in these other institutions that were seeing mostly COVID patients. So it's not as if they weren't contributing or participating. They just weren't the ones that were treating sort of the COVID patients themselves. And so from there, and this was really just our own internal curiosity. This was not intended to be anything more than that. We just thought, wouldn't it be interesting to kind of go look at the data and see which hospitals, originally our premise was the most in the fight and fought the best fight. And by that, we sort of then interpreted it to mean that saw the highest COVID patient volume and had the lowest like mortality rates from that kind of patient volume. So we limited ourselves to January through September of 2020, because that's the only data that we have from CMS so far. And so again, this was also limited to just CMS patients. So primarily 65 and over. So these were the older COVID patients, and these were the patients that had the highest mortality rates. What we weren't able to kind of determine from the data, whether they were like an ICU patient, whether they were a med-surg patient, that type of stuff as well. We weren't really able to kind of look at and risk adjust by comorbidities and stuff to see if they had like sicker patients and that sort of. So there's a lot of unknowns and kind of like this. So there may be, we really can't look at the case mix between this. We really can't look at the comorbidities, that type of stuff. So there's a lot of limitations, which is why this really isn't a scientific study. We can't control for a lot of these variables. And probably the other biggest variable was that there was also uneven distribution of COVID in the US at that time. certain places were seeing a lot more COVID cases than other metro areas and stuff like that. So it wasn't an even playing field for measuring hospitals to hospitals and stuff, because some hospitals had a lot of COVID patients and other areas had very few. So that's why we wanted to not in any way imply that, these hospitals did the best. These hospitals did better than others, that there wasn't others out there that did as well as this. All that we can really, 24 did a really good job. I'm sure there's lots of other hospitals that did a really good job as well, but based on our simple criteria, we just wanted to kind of recognize these 24 hospitals. Now, what we did is we just first looked at volume. And when we got to about 750 CMS patients, we were down to 48 hospitals, that had that level of volume, kind of at the end. Then when we went and we looked at the average mortality rate, which turned out to be 24.6, so extraordinarily high mortality rate in this older population in early kind of COVID. Now, this was also limited a little bit because initially there was no code for COVID. So it had to use like another code. So that wasn't like clean as all. So we know that there's some other patients mixed in here that aren't just COVID because of early on the billing codes. Then the billing codes evolved over time for COVID as well. So we used a collection of billing codes that had used for COVID historically. When we then looked at the 24.6 hospitals that had a lower mortality rate for that generated our final list. And so it's kind of interesting. There's some other exceptions in there just as it relates to hospitals. For example, like NYU Columbia saw a lot of COVID patients, but isn't in our data because they report out through NYU Cornell. So there's a parent-child relationship between these hospitals. And there was in some of these hospitals as well that created the extraordinary volume and stuff. And it's just a function of how those institutions bill Medicare. And that was kind of the data set that we were looking at. But the other thing that we tended to see is there was a very strong East Coast, representation on our list. And so I think this is where it's kind of like we answered our question. And now all these other questions just sort of like emerged, and it was kind of fun to talk about it and try to figure out kind of like what we were seeing there and stuff. One of the things we found out looking at this is hospitals in more densely populated areas tend to be bigger. And these were the hospitals that sort of like the institutions. So what we tended to see, the East Coast far more densely populated than most areas in the West Coast. The East Coast tended to have bigger hospitals, and we were looking at hospital volume and stuff like that. So there's probably an inherent bias towards larger institutions and hospitals, which most of which sort of like, tended to be on the East Coast. West Coast tends to have smaller hospitals, but more of them. And they more kind of match the population sort of density and stuff, and that's the distance from patients to hospitals and those sort of things as well. So which was fascinating for us because these were just sort of things that we never directly sort of like thought about before and kind of discovered as kind of just waiting, through the COVID data. But that's sort of the methodology. It's really not much more sophisticated than the back of an envelope type of thing. But it was an interesting question to us. And at the end of it, we thought it might be interesting to others as well. So we just wanted to share it. And more than anything, we just wanted to recognize these hospitals that saw such a high volume of COVID patients and somehow managed to achieve, below average mortality rates. So the hospitals on our list include Orlando Health, Orlando Regional Medical Center, Houston Methodist Hospital, Advent Health Orlando, St. Joseph's Hospital, Baton Rouge General, Northeast Georgia Medical Center Gainesville, Temple University Hospital, Ascension Providence Hospital Southfield Campus, Methodist Hospital in San Antonio, Advocate Christ Hospital and Medical Center Oak Lawn, Baptist Health in Miami, Yale New Haven Hospital, Lakeland Regional Medical Center, Our Lady of the Lake Regional Medical Center, Baton Rouge, Beaumont Hospital, Royal Oak, Memorial Hermann Southwest Hospital, Houston, Henry Ford Hospital, Detroit, Stony Brook Hospital, Stony Brook, Baptist Medical Center, San Antonio, Lenox Hill Hospital, New York, Ochsner Medical Center, New Orleans, NYU Langone, Health Tisch Hospital, New York, North Shore Medical Center, Miami, and New York Presbyterian Weill Cornell Medical Center, New York. Yeah, it was kind of interesting. I mean, what they spoke about the most was, first and foremost, communication was kind of like the most, for me, it was interesting. The most common theme across all of this is we really just started communicating, meaning kind of like, kind of executives and leadership with kind of the medical staff and that sort of stuff immediately formed these open lines of communications. And there seemed to be sort of also the hospitals that were able to adapt and create new care models kind of dynamically on the fly. And a lot of this, I think, was because of the communication that they kept emphasizing over and over again. The other common theme was about supporting the care providers. There seemed to be a consistent message that, leadership really focused on taking care of the clinicians, the nurses, all of the hospital staff as well. Oftentimes, folks coming out of leadership back into frontline support, positions, patient care, kind of executives now coming in and helping out with patient care and stuff like that, which was kind of like really interesting, as well as making sure that they had like plenty of rest and they had all the PPE that they needed. They brought other clinicians in from other departments and rotated them through kind of care, playing out a position, if you will, to kind of, provide the folks that were getting, the intensivist and, the folks that I think were having the heaviest workloads and stuff. People came from other specialties to help kind of, offload some of the burden and stuff like that. So I think it was just a combination of really creative things, but it seemed to be this tight collaboration though between hospital management leadership and the medical staff at these institutions that made it really work.